Welcome to this interview series of the Arrhythmia Academy on the latest advances in arrhythmia. Today, we are focusing on left bundle branch area pacing. My name is Chipak Lau from the University of Hong Kong, Queen Mary Hospital. Left bundle branch area pacing and his bundle pacing are forms of cardiac conduction system pacing that aim to achieve physiological pacing by restoring or preventing ventricular dyssynchrony. Today, we have two experts with us. They are Dr. Huang from the Key Laboratory of Cardiovascular Disease in Wenzhou, the first affiliated hospital of Wenzhou Medical University from China, and Dr. Puga Zhenhai Vijayaraman from Geisinger Medical Center in Pennsylvania, the States. Both are pioneers in the field. Before we start, I would like to set the scene by showing the slide from the European Society of Cardiology guideline for pacing published in September 2021, with special remarks on his bundle pacing. The recommendations are on the technical aspects and on the indications. When patients are treated with his bundle pacing, the guidelines suggested that special programming is necessary, and a right ventricular backup lead in situations like pacemaker dependency or in which sensing is the issue for electrogram detection. There are three indications listed here. There is a 2A indication when considered as an option for CRT candidates in whom CS lead is unsuccessful. It is a 2B indication, and his bundle pacing may be used in combination with RV backup lead in patients indicated for a pace and ablate strategy, or as an alternative to RV pacing with AV block with ejection fraction less than 40% when more than 20% RV pacing is anticipated. At the time of publication, for the area of left bundle branch area pacing, no recommendations are included because data are scarce. While waiting for the upcoming Heart Rhythm Society ACC document on conduction system pacing, I would like to ask our experts here, Puga and Vijay, and Wei Jing, to address the current role of left bundle branch area pacing and how they would recommend this modality in light of recent research. My first question is addressed to Puga. What are the advantages and disadvantages of left bundle branch area pacing versus his bundle pacing in terms of ease of implantation, durability, and efficacy? Particularly, do you think a backup RV lead is necessary?
Thank you, Professor Lau, for having me in this interview session to be with Vijayaraman. And in terms of his bundle pacing, it's an excellent option for patients who have narrow QRS, AV nodal block, or right bundle branch block. In patients with left bundle branch block and infranodal AV block, we prefer to use the left bundle branch area pacing. And while his bundle pacing, in my opinion, it's still a very good option for AV nodal ablation, sometimes it can be anxiety provoking during the ablation. No such concerns exist during AV nodal ablation with left bundle branch area pacing. Based on the last 10 years, we know that his bundle pacing requires a much longer learning curve compared to a shorter learning curve for left bundle branch area pacing. These things set the scene for the implanter to decide what approach they would use. In terms of electrical performance, if you look at his bundle pacing, at least our center, the success rate has been as high as 90% or more in all comers. And in patients with narrow QRS, it's even much higher. In left bundle branch area pacing, the success rate based on several series vary from 85 to 97%. It's still there's a long process of learning for all of the implanters. And while his bundle pacing thresholds typically tend to be higher than 1.5 volts in more than 10% of patients, but bundle branch correction can be much higher. So those are things to be considered when we do the programming and selecting the particular mode of pacing. While left bundle branch area pacing invariably has excellent thresholds and comparable or sometimes even better than RV pacing thresholds. We do have some sensing issues with this bundle pacing. These concerns are rare, except in situations where there's significant septal scar. And very rare to see threshold increase with left more branch area pacing during follow-up. However, this is not uncommon and may lead to a requirement for lead revisions with hispanal pacing. But frank lead dislodgements are uncommon with hispanal pacing, while it happens in 1 to 2% of patients with left lung branch area pacing. And as I mentioned, lead revisions are much higher with hispanal pacing. So all of these have to be factored in before you accept any particular modality of pacing. In terms of programming, hispanal pacing, as Professor Lau pointed out, needs much more fine-tuning based on the sensing of atrial and ventricular amplitude. Left lung branch area pacing behaves as a normal right ventricular pacing sensing. When we program AV delay, we usually program AV delay 40 to 50 milliseconds, less than the nominal ones you program. In left lung branch area pacing, that's 20 to 30 milliseconds, reflecting the conduction time it takes from the his bundle and left bundle to the ventricular activation. And automatic capture threshold should be turned off at hispanal pacing in most scenarios because the systems do not recognize hispanal capture. However, left lung branch area pacing, this works very well and can be used. And AV delay optimize needed to be done to eliminate right bundle branch block pattern in left lung branch block patients. And thank you.
Thank you, Puga. This is an excellent coverage and comparisons between the two pacing modes. I have a question for Dr. Wang. Wei Jin, the left bundle branch area pacing seems to comprise several different concepts, including left bundle branch pacing, left bundle branch area pacing, and left ventricular septal pacing. Can you tell us how you make the differences between them?
Okay. I'm very pleased to participate in the interview with Dr. C.P. Lau about conduction system pacing. Thank you for this good question. In 1982, William C. Little first reported left interventricular septal pacing in dogs through the right carotid artery. Then in 2002, left ventricular septal pacing was achieved using a lead with an 11 millimeter long insulated screw transseptal root just under the septal tricuspid leaflet. The first in human left ventricular septal pacing was achieved by using modified 3830 lead of an extended 4 millimeters helix at the middle between the apex and the base via venous access. However, these were anatomical definition rather than electrophysiological definition. Permanent left bundle branch pacing was first reported in 2017 using 3830 leads. The lead placed at left bundle area, approximately 10 to 15 milliliters to his bundle region toward the ventricle apex. Now, with deep understanding into these terms, we could have an initial but clear definition. Left bundle branch pacing defined as direct capture of the left bundle branch and surrounding myocardium, while left ventricular septal pacing is defined as capture of the left ventricular septal myocardium only, without the direct capture of the left bundle branch. Left bundle branch area pacing includes left bundle branch pacing and left ventricular septal pacing, with or without direct evidence of left bundle capture. One important thing is that how we distinguish left bundle branch pacing from left ventricular pacing. According to our study, we found that abrupt shortening of a ST LVT by more than 10 millimeters from ventricular septal pacing to left bundle branch capture, and the demonstration of selective LBB capture were the most valuable sign for left bundle capture. Diagnosis of LBB capture can be made based on the above two signs in most conditions. If the left bundle can capture threshold was very close to the left ventricular septal myocardial threshold, usually temporarily. It's rough to differentiate them clearly. We can get the two differential threshold for left bundle branch and local myocardial capture by solo approach, starting pacing test earlier and / or repeatedly, or by changing pacing output, pulse width, pacing rate, or by using program stimulation. Thank you.
Very clear, yes. I would like to ask Puka, can you comment on how you think these definitions can be applied in daily practice and particularly in the field of cardiomyopathy?
Yeah, so Professor Lau, you hit on a very important point. The big challenge for us is how do you assess conduction system capture, especially in patients with left bundle branch block, with using left bundle branch area pacing. Conduction system capture and correction of left bundle branch block is very easy to assess and it's straightforward because it's a qualitative assessment in patients with his bundle pacing. In left bundle branch block and left bundle branch pacing, this requires extra effort. And many practitioners may not do it, and this may have serious implications in patients undergoing CRT, where at least currently we believe that LV septal pacing may not be as effective as left bundle branch pacing. So this is an example of a patient with his bundle pacing with correction of left bundle branch block, showing beautiful pressure volume loops. And the same patient, when because of the high thresholds, LV septal pacing, even though septal pacing was achieved, didn't show as good a hemodynamic response. So I think it's important that we use these definitions very carefully. So first challenge during our assessment of left bundle branch block during left bundle branch pacing is to make sure that it is a true left bundle branch block. Strauss criteria is what we commonly use. It's very sensitive, but not as specific in proving that it is left bundle branch block. However, if we use his bundle pacing as a first step and pace at high output, our experience is that can correct the left bundle branch block in 90% of patients who meet the Strauss criteria. And the incidence of true IVCD in patients with left bundle branch block pattern is not uncommon. It's about 36%, as shown by this very elegant study from the University of Chicago group. By mapping the left septum, they show that the IVCD patients have intact Purkinje activation, and septal pacing or bundle branch pacing doesn't work as well. So we have to use very stringent criteria, as Professor Huang mentioned. And what we use is that these are some of the criteria. So we want to make the anatomical distinction, the lead is in the appropriate location. We look for the pace QRS morphology. While we see the QR or RSR pattern in most patients, rarely you may not see it, so you need to be careful. And left bundle branch potential demonstration is often very helpful by doing corrective hispanal pacing or using the PVCs or escape rhythm, and recording these potential from those is helpful. In addition to these fundamental findings, we need to prove that there is direct left bundle branch capture. We find that this transition during threshold testing from non-selective to selective or non-selective to LV septal capture is very helpful, and it's definitive evidence that it is direct left bundle branch capture. And Dr. Huang has shown that abrupt shortening of the R-wave peak times in V6 by more than 10 milliseconds from a mid-septal position to deep septal position, and which is very helpful. But mapping the left side and showing the left conduction system potential capture is more of an experimental option, but it's still a useful option. And lastly, we use program stimulation sometimes to help us. Peak LV activation time, or the R-wave peak times, arbitrary numbers have been used, but they are not very sensitive and specific sometimes. When you have low numbers, it's helpful. I want to show you some examples. Here's a patient with a wide left bundle branch block. Hispanal pacing, clear to see that there is correction. And during correction, you can demonstrate left bundle potential in the left bundle electrogram, showing this non-select anodal capture in this particular example, showing a lower QRS duration and wider QRS restoration with non-selective left bundle branch pacing. And you can also demonstrate those beautiful left bundle branch potential during correction of left bundle branch block during his bundle pacing. That's helpful. And more than that, the peak R wave times in this example of a patient, we were able to show that the R wave times are 75, which often means it's pretty good. But we were able to show that in his bundle pacing with correction, this particular patient, the R wave times were about 70 milliseconds. So how can LV left bundle branch pacing be longer than his bundle pacing? So this gave us an idea to diagnose, especially in patients with left bundle branch block. We used the his bundle pacing first to show that the left bundle branch block is corrected, assess the peak LV activation time, then use during implantation of the left bundle branch pacing lead, when there is left bundle branch capture, that peak LV activation time should be at least 10 milliseconds shorter than what you achieve with his bundle pacing, because the LV septal pacing tends to be much longer. And this was studied in both non-selective to selective or non-selective to septal capture, and we were able to show the difference that during his bundle pacing and LV septal pacing, then peak LV activation times are longer compared to when you have direct left bundle branch capture. So you can see that the overlap between LV septal pacing and left bundle branch capture is a fairly large region. So differentiating is important, and using a delta R wave time in cardiomyopathy patient with left bundle branch block is very helpful for us to define that there is absolute left bundle branch capture. And we think that is important to be confirming in cardiomyopathy patient, because which is critical to improve clinical outcomes.
These are very interesting ideas to critically address the situation of left bundle branch area pacing. Well, I would like to address to both of you that based on the current evidence and the way we deliver left bundle branch area pacing, do we think that they are in left bundle branch area pacing is good for bradycardic indication or for CRT indication? Dr. Wang, Weijing, can you talk something about your thinking about bradycardic pacing using left bundle branch area pacing?
Okay, this is a good topic. Some studies have shown that in patients with bradycardia, left bundle branch pacing provided better electrical and mechanical synchrony than right ventricular pacing and achieved clinical results similar to his bundle pacing. First, here is a comparison of his bundle pacing and left bundle pacing. We know left bundle pacing provides better pacing parameter, and we'll have a left ventricular synchrony similar to his bundle pacing. But a decision regarding strategy for selection of his bundle pacing, left bundle branch pacing, and left ventricular septal pacing should be made based on our implantation skills and experience, indications for pacemaker implantation, the site block, percentage of ventricular pacing, left ventricular ejection fraction, and pacing parameters. This is a flow chart for conduction system pacing in our center. And the most important thing is that we should confirm whether pacing lead can be placed beyond the conduction block for conduction system pacing. For patients with infranodal AV block, his bundle pacing could be attempted as the preferred choice. If there are procedure difficulty during his bundle implantation, or if the pacing parameter are not satisfactory, left bundle branch could be considered instead of it. Well, for patients with infranodal AV block, for patients with, for example, for patients with TAVI, maybe caused distal his block, conduction block, distal his bundle, and or for those with pacing dependent patients, in patients with AF and post-AV junctional ablation, LBB pacing is the best choice, I believe. For patients with chronic heart failure and right bundle branch block, his bundle pacing may be considered if right bundle branch block can be corrected by his bundle pacing. Here is case with infranodal AV block. The figure showed that regular left bundle branch potential before each ventricular activation with normal potential ventricular interval means that we achieve pacing beyond the block site. This is very important for pacing safety. And here there is a block of AH interval prolonged, and missed beyond his bundle. So if we put the lead at his bundle area, there will be a problem with pacing safety. In patients with a bradyarrhythmia indication and left bundle branch block, conduction system should be considered to correct left bundle branch block in spite of normal left ventricular ejection. That means in sick sinus syndrome, if patient with left bundle branch block, then we can consider conduction system pacing to correct left bundle branch block and not increase economic cost to instead traditional right ventricular pacing. The last, we should remember that there is a concern regarding long-term lead performance and the feasibility of lead extraction for left bundle pacing. Thank you.
Thank you, Beijing. This is a very good overview. Do you normally do all your cases of brady pacing using conduction system pacing, just for interest?
Yes, Professor Lau, in our center, conduction system pacing is performed, and we can achieve his or left bundle branch pacing in 97% of patients needing bradycardia pacing. That's our approach.
Right, yes. And Meijing, what about in your institution? Do you put in conduction system pacing in all candidates for bradycardia pacing?
Yes, because we have performed the conduction system more than 10 years, especially we started digital conduction system, digital his bundle pacing or left bundle pacing. So we have no problem with technique, except patients with March scar in septum. So we have a very high success rate, almost 100%. So till now, we have no problem with safety. So in our center, all patients will receive the conduction system pacing.
Okay, that's very
bradycardia.
Right. Thank you. Yes. Well, the next question I would like to ask Puka, what about CRT indicated patients? How far would you use left bundle branch area pacing?
Thank you, Professor Lau, for this question. I just want to mention at the outset that there are no randomized controlled clinical trials. At least in hispano pacing, there are a couple of small pilot trials. And the available evidence is primarily based on small series and some large series showing significant promise in this population, especially in non-ischemic cardiomyopathy patients. There seems to be a very high hyper-response rates. And we have some observational series and on-treatment comparison that left bundle branch pacing may be as effective alternative to his bundle pacing and biventricular pacing. And the role of left bundle branch area pacing in patients with IVCD is quite unclear at this point. And we have potential for combining both of them in what we term as a lot CRT, where we can use the benefits of both approaches together. I want to mention this particular series that we published in a series of about 17 patients where we had clear evidence for left bundle branch block induced cardiomyopathy. Left bundle branch pacing was successfully achieved in 13 patients. and showed significant QRS duration reduction, but the hyper response rate, the normalization of LV function was 100% in this series. So suggesting that this could be a very good alternative for this left bundle branch block induced cardiomyopathy patient. And in a larger series, we explored this option in a multi-center collaborative fashion, where we looked at about 325 patients with all indications for CRT. And those with ischemic cardiomyopathy was about 44%, and there was IVCD was seen in about 15% of patients, and left bundle branch block was the primary indication for CRT. We were successful in about 85% of these patients. And when we looked at the outcomes, of course, the left bundle branch block patients, similar to the CRT YV studies, showed greater QRS duration reduction, functional class improvement, and LV ejection fraction improvement compared to those patients with non-left bundle branch block. But both groups showed significant improvement compared to baseline, showing that this could be a viable option, if not as a first line, as possibly as an alternative therapy in many patients that require cardiac resynchronization therapy. And recently we looked at the option of combining both left bundle branch area pacing and LV pacing to achieve a greater electrical resynchronization. In this series of 100 patients, QRS duration reduced from 182 to 144 milliseconds by combining both, and showed significant LV ejection fraction improvement during follow-up in this very sick patients. One thing we learned from this is that in a subgroup analysis, it was necessary to have left bundle branch capture to have greater improvement in LV ejection fraction or clinical response. So LV septal pacing, at least in our belief, may not be as good as left bundle branch pacing. So that's why it's quite important to ensure that we have left bundle branch capture. So based on these experiences, our approach is anybody with left bundle branch block morphology, we want to ensure is this true left bundle branch block. You can use any one of these methods, but we often use the his bundle pacing as a first approach to see if the bundle branch block is corrected. If it's true left bundle branch block, well, we want to emphasize to the readers, listeners, that the bi-V pacing is still the most appropriate option. But his bundle pacing, when it completely corrects it, it's an excellent alternative option, especially if you have suboptimal QLV or inadequate CS anatomy, high thresholds. Then left bundle branch pacing can also be used in place of his bundle pacing or bi-V pacing. But in all the other group of patients with mixed conduction disease or IVCD, our approach is to combine both his or left bundle branch pacing together with LV pacing to maximize electrical synchrony and possibly improve hemodynamic response. Thank you.
Yes. Yeah, I think that's a very good summary of the existing state of research. And as you appropriately pointed out, there's no randomized study between the conduction system pacing versus CRT. So some of these we only understand from a limited number of studies, but there seems to be one possible way to go, particularly for non-responders to CRT. Well, our final quick questions I would like to address both of you is left bundle branch area pacing applicable after AV nodal ablation in a pace and ablate strategy? While you're on this, Puga, can you comment quickly on this?
Oh, sure. I think left bundle branch area pacing seems to be a very good alternative for AV nodal ablation. In our center, we would attempt both his bundle and left bundle branch pacing for these patients. As the European guidelines pointed out that some of these his bundle pacing patients may need backup strategy. And our approach is to have both, best of both. And if you have increase in his threshold, then left bundle branch area pacing is available. And I would say currently it's about 50-50 approach. We'll either use his plus left bundle in 50% of patients, or just go for left bundle branch pacing in 50% of patients as a first line itself, based on the electrical characteristics of what we achieve with his bundle pacing.
Right. And what about Wei Jin? What's your practice and what do you think about this approach?
For patients with post AV node ablation, I think LBB pacing is a good alternative for CRT, because we know for patients post AV node junction ablation, the patient is pacing dependent, so we should concern about pacing safety. For horizontal pacing, yes, we can get intraventricular and interventricular signal, but usually for this patient need RV pacing for backup. But for left bundle pacing, can afford better pacing parameter with at least left ventricular septal pacing for safety. So I think in the future, left bundle branch pacing is can be considered for patients with AV node ablation. Our data showed left bundle pacing has a much higher success rate in patients post AV node ablation, and had a similar clinical outcome to horizontal pacing. Thank you.
Thank you very much, both of you. And I would like to conclude here. I believe that we have heard the latest update on the definition, safety, and efficacy of left bundle branch area pacing, and the promising application for pacing in bradycardia, CRT, and after AV nodal ablations. It remains for me to thank both speakers, Dr. Vijay, Dr. Huang, for the excellent input on this truly exciting pacing innovation. Thanks for attending the Arrhythmia Academy expert interview. Thank you very much.
Thank you, Professor Lau. Thank you, Dr. Huang, for having us here.
Thank you. So nice today.